super excited to be welcoming Dr. Vidhath Moku to today's webinar. Thank you so much for taking the time to speak with us. Dr. Moku, a native of upstate New York, completed his undergrad and medical school training in Erie, Pennsylvania at Gannon University and the Lake Erie College of Osteopathic Medicine. He subsequently continued his training for his primary specialty of physical medicine and rehabilitation at SUNY Upstate, where he was involved in academic pursuits through research, teaching, and ultimately served as chief resident in his final year. He continued his subspecialty training in pain medicine with world-renowned faculty at the University of Michigan, where he trained extensively in image-guided interventional pain procedures and advanced neuro-modulation techniques. With a holistic, function-focused approach, Dr. Moku is dedicated to helping patients restore their mobility, relieve pain, and return to the activities they enjoy. For Dr. Moku, effective healthcare is a partnership. He works closely with patients, ensuring he understands their needs and communications clearly, to develop a unique treatment strategy designed to enhance their well-being and ability to function. Dr. Moku, thank you so much for joining us, and we're so excited to hear from you. Is there anything else that you'd like to share and add to your introduction? Please feel free to fill in anything that you think I might have missed.
Sounds good, Sanjana. Thank you for having me here.
Yeah, of course. We can go ahead and get started with the questions then. I want to start off with a kind of introductory brief question. Could you start by giving us an overview of your role as a physical medicine and rehab interventional pain medicine specialist? So what does this entail in a brief explanation?
So in a nutshell, I would say it's like functional based medicine. So any medical decisions we make is keeping the goal of improving people's functional activities, say like dressing, moving or ambulation, things like that. So those are kind of our objective metrics that I personally keep in mind before I consider an intervention for somebody.
And I'd say, I mean, me personally too, a lot of students aren't as familiar with pain medicine and rehab. How would you say, and to explain to anyone, how your field differs from orthopedics, neurology, or physical therapy, for instance?
So there's a lot of every medical decision, at least in the inpatient rehab setting for physical medicine and rehab, involves functional improvement, say dressing, bathing, the things that we take for granted usually. So those are the kind of metrics that we look for when we make medical decision making in terms of care, at least with physical medicine and rehab. And then interventional pain, it depends on your background. If you're anesthesia, you're going to have a different philosophy. As a physiatry-based doctor, when we do, say, minimally invasive procedures, injections, it's all with a goal to do pain reduction. So people can, say, participate more in therapies or, in exercises, get stronger, and then be able to do the things that they would normally be able to do.
And you mentioned minimally invasive procedures. Does this just encompass injections, or what other procedures do you normally take care of?
We do spinal cord stimulation. There's sacroplasty or sacral fusions. There's, for lumbar spinal stenosis, we can put in spacers to open up that kind of space. There's also what's called the minimally invasive lumbar decompression procedure, where if there's what's called the ligamentum flavum, I don't know how well versed people are with anatomy on here, but when that structure thickens, it can cause compression of the spinal cord that can cause weakness of the legs. So basically, under X-ray guidance, we can go in and debulk that ligament to alleviate some of the pressure on the spinal cord. And then there's a whole host of ultrasound guided injections, and then peripheral nerve stimulation as well, not just within the spinal column as well. So those are kind of a broad spectrum. And then like kyphoplasty, if someone has a vertebral body fracture, which involves restoring the vertebral height, let's say.
Perfect, thank you. I was also wondering if you could walk us through your journey from undergrad and med school to your current, or to residency at SUNY and then your fellowship at UMich. So the process of your training essentially.
Yeah, absolutely. So out of high school, I actually applied to a combined program. So I did a combined program, BSDO. Ironically, it was with a different school, but in undergrad, I kind of had that safety net of, there's a program that already wants me. So, I was doing a lot of extracurricular activities, nothing compared to what you guys are doing now, not even close. But, there was like Biological Honor Society, like Tri Beta. So my typical day would consist of, going to lectures, studying, and then the extracurricular activities such as the Tri Beta Honor Society. And then, so I started studying for the MCAT around, I think, sophomore year. Had to take that a couple times. That wasn't an easy exam. And then junior year, I applied. Senior year, I applied. And then I was in a 7-year program, but I had to kind of break that contract because there was another school, LECOM, I wanted to go to instead. So senior year, I applied, and then got accepted, I believe, in like February, and then started med school in July 2020. So, 2016. Sorry, 2020, I graduated. I'm losing track of time here. But med school, so how our med school worked, my pathway was that we had lectures were mandatory. So Monday through Friday was like 8 to 5, and you have to attend lecture or else you'd be eligible to fail the exam. So it would be classes from 8 to 5, and then after classes, take a little bit of break, study until say 9 or 10, and then I would say probably Saturday evenings I would take off because you need rest. That's I know you guys are pushing the pedal to the metal all the time, so that's probably what if you hear nothing else that I say today, it's make sure to get enough rest and sleep. But then junior year of med school, so the third year of med school, you do your rotations. You're kind of expected to know what you have an idea of, like what kind of specialty you want to do, probably end of sophomore or the second year of med school. But I think more and more med schools are shifting towards being able to do sort of like a shadowing opportunities in like second year of med school. So I think that's nice for you guys moving forward. Because I feel like it's a lot of pressure if you don't know. It's wide open. There's so many specialties. So I knew third year of med school that I kind of wanted to do physiatry. So I did a couple elective rotations, ended up applying, and then you have to go through what's called the match process, where you rank and then keep your fingers crossed. Hope you go somewhere you like, and then in March of senior year, you find out where you go. So then you start residency. Everybody starts July 1st. So I did a transitional year, which is you have to do an intern year depending on the program. So I ended up doing a transitional year in Poughkeepsie, New York, which involved multiple different rotations. It included internal medicine, surgery, all that. And then I started physiatry in July of 2021. And then that was like 3 years of physiatry residency. That's where the core of my training was. Lots of academic pursuits while you have med students coming to you. However, the first year you're not really, you don't know a whole lot to teach them, so they're looking to you. So it's kind of like fast-paced learning, but nothing you guys won't be able to overcome. So then junior year of residency or third year of residency, third year of residency, you kind of decide whether you want to super specialize or do a fellowship, after which point you can't really do away rotations in residency. So you just kind of look to your specialized attendings and then you apply out and then you do again the match once more. So then I did the 1-year fellowship and then I took a few months off actually because there's no need to. I felt that I needed a little bit of rest before I started the job, and now I'm here.
That's amazing. I'm actually super intrigued by your journey, so don't mind the follow-up questions. But you said that you graduated undergrad and went to med school in 2016, correct?
Yep,
So then you started residency in like the thick of COVID, if I'm not wrong.
that's exactly right.
How was that process?
Um, it was a lot to handle because some of the transitional care floors are like regular medicine floors were patients that were on the cusp of being in the ICU, but not necessarily in the ICU. So you had to perform like ICU level care without having all those ICU attendings or equipment available. So you learn pretty quickly how what you're made of. So everybody has that self-doubt when they start, but it was a very unique experience. We had no idea about what COVID was like, what it can do. Some of us were probably more, uh, let's say, reckless. We're like, it's fine, we'll be all right. But
Mhm.
you kind of change it. It changes your perspective. People can change in an instant, their clinical condition and stuff. But it was a good experience.
And do you feel like by the end of your residency, you were kind of out, like, were those concerns kind of out the window by the time you were nearing residency?
Absolutely. I'd say, by the end of the first year, you're already way more confident than when you started. And that's with if you I've, not to call out my co-residents, but some of them didn't do any reading at all. And even with sheer volume and repetition, you just become more confident by the end of the year. And there's graduated responsibility. So the attending kind of overlooks you. The oversight decreases over time, and you inherently get a sense of increased responsibility. So if you don't know, you're either going to find someone who knows, or you're going to try to find the answer through reading, however you got to do it. But it's funny the way that works, because by the end of it, everybody becomes competent.
That's perfect. I was gonna say too, during medical school, I know a big thing now, or people are concerned about is pass-fail grading versus not pass-fail grading. Can you talk a little bit about what your grading was like during medical school?
So our school still had grades. So
Okay.
I think a 70 might have been pass. So sometimes it would create a sense of anxiety, like there's always kids in med school that are wondering about how you did.
Mhm.
Um, but once you stop focusing on that and focus on like whether you know the material or not to sound cliche, I think the pressure became a lot less. So I think with pass fail, it's a excellent idea in with med school grading itself, not necessarily the step exam. I think it takes a lot of pressure off of a lot of people. There's extremely talented people that sometimes cripple under pressure because of grades that would otherwise make excellent physicians. So I think that's a positive trend for you guys.
Amazing. That's so good to hear. And can you talk to us about the differences between MD and DO and why you chose to pursue DO specifically?
Yeah, absolutely. So the core training is the same, but there's a minimum of 250 hours of osteopathic manipulative training or manual muscle training. I think it really made me a better diagnostician and clinician. Some specialties, obviously, you're not going to use it as much. I'd say, like internal medicine, you may not use it as much, but any of sort of the neurological musculoskeletal specialties, say like, physiatry, neurology, orthopedics, neurosurge, even, I think it'll make you a better clinician. So I think that added training kind of gave me made me a better at my physical exam as well. So
Got it. Thank you. And what initially drew you to physiatry and then later to specialize in pain medicine?
so physiatry, I would say my father's trained as a physiatrist and so is my brother. But aside from that, I would say like in it's one of the specialties you feel you can see like gradual improvement. You can see the tangible improvement of your work. So if you're working in the inpatient unit, inpatient rehab unit, you get people with like debilitating strokes, like no motion on half the side of their body. You're involved in the medical decision making and care, and by the end of rehab, some of them, can move their arm, they can actually feed themselves, things like that. So that was like that sort of gratification. I was kind of chasing that. And then interventional pain afterward, I would say, some of these people have like these complex pain conditions that have been untreated, that have been debilitating, and they're not able to do some of their daily activities. When you can recognize that problem and treat that problem, it works almost instantaneously, and that gratification is like next level. So I was like, that's something I want to be part of.
Hmm. And did you already know that this was something you were interested in even when you applied to the VSDO?
No, actually, I didn't. It was on my radar, but I was relatively open-minded. I was thinking internal medicine, I was thinking orthopedics. There was a couple different things that I had an open mind regarding. Um, I'd probably say like general surgery was something I was not interested in. So that was probably the only thing where I was like, I'm probably not going to do that. But everything else I was relatively open-minded about.
Got it. And we do have some high school students who are part of PhysiLink as well. So I wanted to ask, could you give some insight into what you did during high school to make you feel more prepared when applying to these programs and what you feel have helped you stand out?
So I personally did a lot of volunteering at the hospital. I think I know some people say like, oh, that's cliche. Everybody does that. No, it counts. Have good extracurriculars. Don't go overboard because you're going to burn out.
Mhm.
Make sure you're studying. The grades are important, obviously, but as far as like extracurriculars, do what you can. I think I did like National Honor Society. Um, that was one of the things I did. If you play sports, that always adds into. And then as far as like the essay, I think is important because they take pretty close look at it. So if you yourself are not that great at writing essays, but someone who writes good essays, have them proofread it for you. Um, Try to form close mentorship with some of the physicians. They can write you a nice letter. Someone who is eloquent with their words. If they can write a recommendation letter for you, I think that'll help too.
Amazing. I know your fellowship training emphasized image-guided interventional procedures and neuromodulation techniques. Could you explain what these are and how they've advanced pain medicine and management?
So as far as like image guided techniques, so the most we use is a fluoroscopic machine. It's kind of like an X-ray machine. It increases the accuracy of where you're going to a particular nerve root or structure for the injection. Ultrasound is becoming more and more important um, for locating, smaller nerves, musculoskeletal structures. I feel like, classically knee injections in the past, like 70s, 80s, 90s, even 2000s, have been done with landmark based, meaning you just go to the area where you think the space is and inject. I feel like ultrasound guided has improved the accuracy of depositing the medication in the right area. Um, so I think, and then neuromodulation techniques, that's still expanding. Um, Basically, you're putting like electrical wires to block pain signals and replace it with a sort of different signal. Um, so that can kind of improve chronic pain in a more crude form, if I would say. That was more of a crude explanation, but
Got it. No, thank you. That was perfect. And being named chief resident is a major accomplishment and super impressive. Can you talk to us about what exactly you do as a chief resident and what that entailed?
yeah. So for one thing, that's not something I wanted to do actually, but sometimes there's two reasons to be chief resident. One is if you want to take on that administrative role, or if number two, the alternatives are much worse. So if some of your co-residents are going to drop the ball, then you have to step up. So the role with chief resident, you're essentially like a liaison between the attendings and the residents. You manage the schedules. If you're an academic chief resident, you organize like the lectures. And then if you're with your co-chief, you can kind of mix and match your duties, but it sort of gives you experience into more of the administrative side of medicine.
And do you feel like that helped prepare you at all for now in your fellowship or in your fellowship training now as an attending?
Yeah, absolutely. Because as an attending, you're going to be the leader of a team, and you have to be okay telling people what to do sometimes. And sometimes it may be things they don't want to do, but isn't required for like patient care. So I think it kind of gave me practice um, with that, telling co-residents like you guys got to kind of step it up, or you guys are kind of, you know, I was told by an attending, these are sort of the mistakes that you may have made. Here's how to correct them, kind of. So troubleshooting, team leading, definitely useful, I think.
Thanks. And as a resident, what does a typical day or week look like for you, and how do you balance any procedures, clinical visits, and patient follow-ups?
You're saying as a resident?
Yes, during residency.
So it was, I would say 8 to 5 was the typical schedule for me in residency, but sometimes for like the outpatient clinics, you'd have a full day, like 13, 14 patients. So what I would do is at home, I would prep the notes, which would probably take me an extra, I don't know, like an hour, hour and a half. But that makes the clinic day go by faster. So if you're reviewing as you're seeing the patient, the attending is going to have less time to teach you, and you're going to know less about the patient, and you're going to be more focused on the notes. So I think those are kind of the tips and tricks to um, bypass that. And it also depends on the EMR that you have in residency. So if you have Epic, which I'm sure a lot of you heard of, it makes chart reviewing so much easier. And so I would say my schedule was typically 8 to 5. I'd probably get in closer to 7 on the inpatient days, and outpatient days I'd probably get in right around 8 because my notes would be already pre-prepped. So I think note prepping is probably keys to being a successful resident.
And was that generally the same schedule throughout the whole week, or did it change day by day?
So that was typically the schedule throughout the week, unless if you're on call sometimes, then it can change. You, but like you'd have to work the weekends at some point if you're on call for that week. But usually for PM&R, I would say it's 8 to 5 schedule.
And then during your last couple years of residency, what does your interaction look like with medical students versus the attending?
So the attending, essentially you become a junior attending. The attending really does not, unless they see some gross negligence, they're not going to really bother you. As far as like med student interaction, so you're essentially functioning as a junior attending. So say some of the more easier injections, say like trigger point injections, I would let, I'd supervise the med student. I'd be like, here's how to do it. The teaching became a lot more streamlined. You're more sure of what your specialty is and what the medical conditions are, so you're able to teach better, I feel like. And that's certainly something I enjoyed.
And does this continue on during fellowship as well? What does your role look like in fellowship training?
So fellowship training is even more hands-off from the attendings. So you get residents, you get students, you get residents from other specialties. So for us at Michigan, we were kind of like the clinic leader. You dictate who sees what patient, how the flow is. And if they have any questions or any issues, you're the person that's going to troubleshoot that. So essentially, it's like graduated responsibility, but you get the hang of it over time. So
Good to know. And you obviously you chose to pursue pain medicine fellowship. Can you talk a bit about other options that there are for fellowships after you do physiatry residency?
yep, absolutely. So you can do what's called interventional sports and spine medicine. That's it's similar in the sense that we do the same interventional procedures, but there isn't as much acute pain service in the hospital. So that's one. Another one is wound care fellowship, managing um, wounds of the lower extremities, upper extremities, sacral wounds, bed sores, that kind of thing. There's also brain injury medicine for anybody that sustains a traumatic brain injury. There's spinal cord injury medicine. I feel like I'm missing a couple, but those are sort of the main ones that people go into.
Well, I had no idea that there are so many specific fellowships from physiatry. You also emphasize, and we heard before, a holistic function-focused approach. What does that look like in practice for you?
So when I evaluate a patient, I first my first question is, what's your understanding of why you're here? And then at this point, it's pain focused. So I say, my follow-up question is, what is it that is limiting you with this pain? What are you being limited by, or what is the pain limiting you from, essentially? And when they answer that, that kind of creates a sort of expectation. Like if we reduce the pain, these are the things that if you're able to do this, I can say there's an objective measure of success of what we did. If not, then we go to a different treatment. and see if we can kind of restore what it is that in particular that you want to do. Like, for example, today I had someone who wanted to golf. He's not able to golf because of low back pain. So I'm not going to necessarily do a different treatment, but I will know, is there something else to do if he's not able to golf after we do a particular treatment? Kind of puts things into perspective, I feel like.
Got it. And going off of that, chronic pain can deeply affect both physical and emotional health. How do you approach helping patients manage that pain while improving their quality of life and supporting them on a more emotional aspect?
So this is one of the hardest parts. I would say setting expectations. Like here's what I can offer, here's what I can do. Letting them know that, there's not one silver bullet. The emotional aspect obviously is huge. So I say, like, here's what I feel the expectations could be. What are your expectations? And what do you hope to achieve as we move forward? And kind of letting them know that, it's not going to be just one thing that helps them out, helps treat them. And I think that kind of helps them see the broader picture, realizing that, it's not just one intervention that's just going to automatically take the pain away or like, improve their emotional mood. Essentially emphasizing the multimodal approach to treating them.
And I love that this sounds like such an open conversation. I know you said you ask what their expectations are. How do you navigate the situation in which you might not necessarily be able to fully help with whatever their specific expectations are?
So that's what you'll find is to be the hardest thing when you say you can't do something, or you don't have a solution for a patient. But I found that it's best to be, upfront and honest and being like, these are within my skill set. I can't, there's nothing I can do for you, but I may be able to find someone who can. So I think that creates a sense of honesty with the patient where, although they're disappointed, I feel like the understanding is better when you're able to kind of go that approach.
And are there common specialties that you often find yourself referring patients to if it's something that you wouldn't be taking care of?
So some providers do narcotic management for medications. I will refer to them. Other ones I'll refer to, neurology for some complex, peripheral neuropathies that if I'm not understanding what's going on necessarily, if there's like a surgical emergency that I obviously can't treat, if they're having like sudden onset weakness, bladder, that kind of thing, I'll refer them to neurosurgery, things like that.
Got it. What recent innovations or technologies, if any, in pain management are you most excited about? Whether that be, I know spinal cord stimulation is a big thing, virtual rehab is a big thing. So, what are the things that you're most excited about?
So now there's a spina spacer, a minimally invasive technique where for central canal stenosis, you don't need to do open surgery in the right patient, of course, where you can open up the canal with a percutaneous device. So that's kind of the big thing that I'm noticing. That's not necessarily just let's say, Band-Aid. It can actually improve patients' ambulation and walking. So that's the thing I'm probably most excited about right now. And there's developments going on in neuro-modulation as well as we speak. I'm excited to see what comes of it.
That's amazing. And I'm sure you've gotten this topic a lot recently, but do you see AI helping at all with your specialty or in general your day-to-day work?
Absolutely, yeah. So we have a AI scribe essentially that's like uploaded onto the Epic EMR. So I've never used that in residency or fellowship. So day one was the first time I was like, I ripped the Band-Aid off. I started using it right from the jump, and it makes it so much better in the sense that I don't have to worry about typing because when I type, I have to focus some energy on that, and I miss some of what the patient is saying that may be important. With this AI scribe, I can have a direct conversation with the patients face to face, and I'm not doing any typing now, so I can focus on the physical exam history and just essentially talking to them. And any minor tweaks that I make to the note will be after the encounter. So I think we're in a good spot for AI right now.
Does it play a role at all in diagnostics as well?
I think it can, but we're probably in the infancy stages, so I wouldn't necessarily bank on it, but if there's someone checking it over, I think it's reasonable and it's helpful, and it may, assist you with ideas that you wouldn't necessarily think of too, of diagnoses. But to solely rely on it for diagnostic purposes, I'm probably going to say no.
Yeah, for sure. And I guess looking more towards the future, how do you see the field of pain medicine evolving in the next decade, especially with growing awareness of opioid alternatives and integrative care approaches?
So I think it's going to go towards the side of like minimally invasive neurosurgery. A lot of the procedures being done now are similar to what open spine surgery can be done. So it's already heading that way, and I think it's more and more it's going to be heading that way. Um, there's some pain physicians that are doing sort of um, neurosurgical procedures with like a percutaneous camera and things like that. So I think the field is going to be headed that way, especially because people are trying to gear away from long-term opioid use.
And can you talk a little bit for those who might not know what minimally invasive neurosurgery entails?
So essentially, like it's like the spinous spacer procedure. Instead of doing an open surgery and going in, it'll just be a small nick with a scalpel, and then you go in with sort of like a trocar and then deploy the device. So the procedures kind of involve all of those involve similar techniques in terms of like making a small skin nick and going in instead of having them being opened up.
Okay. And from your past training, we've heard that you've trained and practiced in several regions from upstate New York to Michigan. Has that geographic diversity influenced your approach at all to patient care or given you a different perspective?
Yeah, absolutely. So upstate New York, more small town feel. Michigan patients, I felt like may have been at times a little bit more wild, and at academic center too. So that's the other thing. When you're at the University of Michigan, these people have been through a few different pain providers, so the expectation is that you'll automatically have a magic answer that no one else does, which is not necessarily the case, quite often not the case. Um, and then here in South Carolina, the people are just extremely friendly and thankful. So here, they've made my job easy. So, but approach wise, I was taking the same approach as I was, I would say, in New York, Michigan, and here. But here, I think they may have been a little more receptive and more appreciative, even. So.
Have you seen a change at all in complaints that people come in with between the different areas, or is it generally pretty much the same across all boards?
I would say it's pretty much similar
Okay,
overall.
got it. And looking back, what do you feel like is the most rewarding part of your training, as well as what was the most challenging in all of these years of training?
Rewarding part of training. I would say, the being able to take care of patients, the privilege of taking care of patients is probably the most rewarding. I've been fortunate to have good mentors that kind of um, were able to tell me when I didn't know things, how to learn things, how to go about approaching things. So that's probably been the most rewarding thing. The most difficult thing throughout residency and fellowship is being able to say, I don't have anything for you. So
Hmm.
that doesn't come naturally. As you guys will see, like, when someone comes in, you're like, there has to be something that I can do for you. But being able to, run through all the options and being like, I don't have anything, unfortunately, for you has been learning to say that has been the hardest thing, and learning to say no as well sometimes.
Hmm.
Those are two things I think um, will be important to learn, and it'll take time.
Definitely. And you mentioned mentors. Were there any key mentors, patient experiences, or turning points that you feel shaped your career path?
Yeah, so there was an attending I had at Michigan, and his entire thing was if they're having burning pain going down in an area, there has to be a nerve involved. So he was like his approach was no stones unturned. He was also very intelligent, but I think that kind of uh, set an impression upon me that that you should go with a no stones approach, no stones unturned approach to patient care before you say there's nothing I can do for you.
For sure. And from the perspective of students or the perspective of patients, do you feel like there are any common misconceptions about your specialty in particular, whether that be physiatry or the pain medicine subspecialty as well?
So physiatry, I think not a whole lot of people know about. So as far as like misconceptions, I didn't hear anything universally. Pain medicine, I think it's still people are seeing the documentaries, of like the big pharma with the opioids and stuff like that. So I think there's a common misconception that the bulk of what we do is hand out pills, which it's swapped over. It hasn't been that way for a while now. But even patients as well that come in, uh, they come in asking narcotics, sometimes not knowing that there's other alternatives, procedural alternatives as well. So I think that's one of the biggest misconceptions. But by the time you guys, get into training and stuff, I think it'll switch. That misconception will be overridden.
I hope so, yeah. And I know you started the webinar early on saying that it's so important to find a balance with academics and not burning yourself out, taking breaks, all of that. Outside of medicine, how do you personally unwind and maintain a work-life balance and making sure that you avoid burnout?
So I go to the gym every day, so that's that kind of takes it away from it, takes away from the medicine part of it. And once I'm home from work, unwinding with a little TV, a little relaxation time. Once the notes are done before sleeping, maybe an hour or two, just do something that you find relaxing. For me, maybe TV, video games actually has started up again, so I've had some time now. So
Mhm.
so I think that's how I keep the stress of the medical stuff away.
Do you have a favorite TV show recommendation?
So I'm watching The Good Doctor right now. It's pretty good.
Okay.
Um, I feel like it's a little more realistic than the other ones, and it's entertaining. And Freddie Highmore is a good actor, so I think that's something for you medical buffs out there that will enjoy. It's not too realistic where you're like I don't want to watch this, and it's not too fake where everybody has a unicorn diagnosis that gets saved. So somewhere in the middle, it's pretty entertaining.
And just out of curiosity, I know you went to school in Pennsylvania, so you're familiar with the area. Have you watched The Pit at all?
I have not yet.
Okay. We'll have to hear about your thoughts later on then.
Absolutely.
Yes. Okay, as we wrap up, nearing 6:50, is there any other advice that you'd like to share before we conclude, keeping in mind that most of our attendees and watchers are pre-med students, also some high school students looking into the medical path?
Yeah. So take breaks, obviously. Um, Taking a year off is not a bad idea. So
Mhm.
as someone who went right through, looking back, it wouldn't have hurt to take a year off. So there's nothing wrong with that. And if you don't get in the first time, keep trying. Um, it's not the end of the world. Sometimes good candidates get missed for a variety of reasons. The process itself is not perfect. So just keep trying and make sure to take care of yourself. The mental health aspect of it, medical school will already deteriorate you. So don't go in with a deteriorated mindset. Stay fresh. And it is okay to take a break. It is okay to take an evening and not study. You will be okay. I promise. You look back 10 years down the line, you're like, shouldn't have pushed myself like that. Taking a day off here and there is not going to hurt you. As a matter of fact, if you're mentally fresh, you're going to do better on your exams. You're going to do better clinically. So that's something I want to impart upon those who are listening.
And for people who might be unsure about taking a gap year or are thinking of doing one, do you have advice on what to do during that gap year? Should it be something medical related, non-medical related? What are your opinions?
I think you should just stay busy. Um, Obviously, if you want to do some traveling, things like that, you should definitely do that. But if you can do medical stuff, you can do research. I don't think it necessarily has to be medical. But when you're reapplying, I think it may be important just to say, I was doing these things over the year, keeping yourself busy. But I don't think it definitely necessarily has to be medical. And you have that year kind of relatively free, so make sure, you travel, spend time with your family. Because in med school, that's going to cut down a lot. So you're going to miss stuff in med school. So I think that's probably the important thing to keep in mind when you take a gap year.
Sounds good. Thank you so much. If anyone has any questions, please feel free to drop them in the chat. If not, we can go ahead and wrap up. Dr. Moku, we truly appreciate you being here with us this evening and taking the time to share your experiences and all of your lessons with our listeners. To everyone who's watching us, thank you for being part of this conversation. If you have any additional questions that you didn't get to ask today, please feel free to submit them on our website to be answered by Dr. Moku, and we'll make sure that we get those answers to you. Like I said before, a recording of this webinar will be available on our YouTube channel, and you can also catch it as a podcast episode soon on Spotify. As always, feel free to reach out to our PhysiLink team with any questions, and the contact is listed on our website. On that note, thank you again for attending, and we hope you all have a wonderful rest of your evening. Thank you, Dr. Moku.